Welcome everyone to this ISDE webinar. I'm Simon Law from the University of Hong Kong, and to chair the webinar with me is Professor Lawrence Ho from the University of Singapore. Well, as you know, COVID has been traveling around the world, and the ISDE World Congress, originally scheduled this year in Toronto, has been postponed to next year. So the board of ISDE decided to have this initiative to keep it going, and we will have a series of these types of webinars for all the members as well as non-members around the world to keep your interest in the esophagology and ISDE, and this is the first one we have decided to host. And today we're going to talk about the multidisciplinary approaches to achalasia, and I hope you'll enjoy it. So now let's, without further ado, let's start. To begin with, we'll have Vani Konda from the Baylor University Medical Center. She is the clinical director there at the Baylor Scott and White Center for Esophageal Diseases. And she is going to talk to us on update on the pathophysiology and workup for achalasia. Vani?
Thank you to Professor Law and Professor Ho and the ISDE for organizing this roundtable discussion on achalasia. It is my pleasure to provide an update on the pathophysiology and workup in achalasia. As we know, achalasia is the major motor disorder of the esophagus. The classic presentation of achalasia is characterized by peristalsis and the failure of relaxation of the lower esophageal sphincter. This disease typically manifests itself in adulthood and can be progressive and insidious over years. The natural history is such that early stages of the disease may have non-specific symptoms of chest pain and be misunderstood as heartburn. Then middle stages may actually be asymptomatic as the esophagus becomes more compliant. And it is not until late stages that we actually see the more obvious symptoms of solid and liquid dysphagia and regurgitation, and those concerning complications such as pulmonary aspiration and weight loss. While we speak about muscle in achalasia, it is important to understand this is a disease that stems from nerve damage. At a basic level, there is an insult to the myenteric plexus, which causes inflammation and then destruction of the neurons, which then leads to the motor dysfunction characterized in classic achalasia. While in South America, there's a well-known association between the parasite T. cruzi and Chagas disease, which includes an achalasia-like process, most cases of achalasia are thought to be idiopathic. There have been proposed etiologies that include viral infections, genetic associations in rare familial cases, autoimmune pathology with specific HLA class associations, and traumatic injury. To add to the list, I will share another possibility proposed by our group under the direction of Dr. Souza and Speckler. We hypothesize there is an allergy-mediated process that potentially may be responsible for a subset of cases of achalasia. Presented in abstract form, we evaluated the muscle specimens from patients with achalasia obtained by laparoscopic Heller myotomy and control specimens obtained by organ donors. Tryptase immunohistochemistry staining was performed as shown here in representative images to demonstrate mast cell and mast cell degranulation. While mast cells were found in both, the controls had intact mast cells as shown in panel A, whereas all the cases of achalasia had large quantities of degranulation products noted around the nerves in the LES myenteric plexus, as shown in panel B. With mast cells being an important mediator of allergy, our group is furthering this line of investigation with ongoing studies to ascertain if there is a possible allergic trigger in a subset of cases with achalasia. This diagnosis of achalasia is typically made by history and a combination of diagnostic tests. Commonly, we can see on barium esophagram the loss of a primary peristaltic wave, a dilated esophagus, and a narrowing at the GE junction, sometimes referred to as the bird's beak sign. End-stage disease, as shown in the middle panel, may also demonstrate a tortuous esophagus with sigmoidization appearance and gravity-dependent areas of collection that may lead to sump effect. A barium tablet may also be administered to see if passage into the stomach is impaired by either a stricture or impaired LES relaxation. Another additive component that is useful in patients with achalasia is a timed barium esophagram, which characterizes the clearance of the column of contrast and can be utilized for comparison pre and post intervention. On endoscopy, we can see a dilated and tortuous esophagus, sometimes food and fluid filled, chronic stasis changes of the lining, and a tight LES with sometimes a characteristic pop when entering into the stomach. While esophagram and endoscopy are often able to detect classic and often late stages of disease, the radiographic and endoscopic manifestations of earlier stages of disease or variant presentations may be more subtle and less apparent. The advent of high-resolution manometry and esophageal pressure topography have enabled a broader detection of disease with improved ability to characterize and classify swallow function compared to the predecessor of water perfusion system. This transnasal catheter has 36 solid-state sensors spaced about 1 centimeter apart and can detect pressure along the length of the esophagus, to then be extrapolated into a color-coded pressure, space, time plot to assess the esophageal sphincter and primary peristalsis. Objective metrics that are incorporated into the Chicago classification system can be determined through the software program, such as integrated relaxation pressure, or IRP, which reflects the relaxation function of the LES and is the average lowest pressures in the non-consecutive time period of the 4 seconds of the swallow. The distal contractile integral, or DCI, which reflects the vigor, and the distal latency, or DL, which is the time from the start of the swallow marked by the UES relaxation to the contractile deceleration point, which is the inflection point of the swallow. High-resolution manometry is the standard test to diagnose achalasia, which can be characterized by impaired LES relaxation and lack of organized peristalsis. This basic test includes TENS wet swallows. Adjunct maneuvers may be incorporated to protocols, including upright swallows, multiple rapid swallows, and viscous swallows. We recognize there is often a delay in diagnosis in patients with achalasia. This is commonly because regurgitation is often mistaken as gastroesophageal reflux disease. When considering a diagnosis of achalasia, it is important to consider GERD, eosinophilic esophagitis, and malignancy, which can sometimes mimic achalasia, called pseudoachalasia, either by direct compression at the gastroesophageal junction or through a paraneoplastic syndrome. Confounding states manometrically include post-surgical states, complex hernia, and distal esophageal strictures, underscoring the need for an endoscopic examination and importance of taking manometric evidence in the overall clinical context. There have been different iterations of Chicago classification, and we are currently on version 3.0. In looking at these disorders with an outflow obstruction, the current Chicago classification delineates 3 types of achalasia. Classic achalasia is type 1, characterized by an IRP above the upper limit of threshold of normal, depending on the type of HRM system used, and 100% failed peristalsis. Type 2 is characterized by an IRP above the upper threshold with 100% failed peristalsis and 20% or greater with panesophageal pressurization, which is the compartmentalization of pressure from the UES to the LES at the threshold of a 30 millimeters of mercury isobaric contour. Type 3 is characterized by an IRP above the upper threshold of normal with no normal peristalsis and 20% or greater with premature contractions, which is marked by a low distal latency less than 4.5 seconds. This classification of types of achalasia are useful because they have specific criteria we can objectively determine on HRM, and also because they can be associated with prognosis and response to treatment. For example, type 1 is typically the end stage of disease, manifested with a dilated esophagus, and accordingly only has a fair response to treatments. Type 2, on the other hand, is touted as the subtype with the best response to treatment and can benefit from any of the major treatment strategies. While type 3 is associated with the worst prognosis, identification of a spastic achalasia does warrant consideration of a POEM approach, which can allow for a longer myotomy. It is important to understand that though these classification systems fall into three specific boxes, it is possible to have symptomatic cases of achalasia-like dysfunction that fall outside of these boxes. And that brings us to EGJ outflow obstruction, which is a heterogeneous condition such that there is an elevated IRP and sufficient evidence of some peristalsis, such that criteria for types 1 through 3 are not met. EGJ outflow obstruction may be an early form that may eventually progress to achalasia, incompletely expressed achalasia, or some other variant form of achalasia that exhibits patterns of dysfunction not captured strictly by failed peristalsis, panesophageal pressurization, or premature contractions. Patterns of motor dysfunction and nerve innervation are useful in understanding the range of phenotypes and patterns of progression that exist in these motor disorders. Specifically, the distal 2/3 of the esophagus receive vagal nerve stimulation by way of two lower motor neurons to the smooth muscles, which are excitatory nerves and inhibitory nerves. This imbalance of excitatory and inhibitory signals is what may lead to the different patterns of achalasia and major motor disorders of the esophagus by impairing the function of peristalsis of the esophageal body and relaxation of the lower esophageal sphincter. Prior to complete neuron destruction, fibrosis, and loss of tone in the esophagus in classic achalasia, we find that other subtypes may reflect earlier stages of disease. For example, achalasia with panesophageal pressurization may reflect an earlier stage where the esophagus is still capable of compartmentalized pressure, and there may be some preserved peristalsis prior to that. If we explore early inhibitory neuron inflammation or destruction of the esophagus, it may lead to an unchecked excitatory process that leads to premature contractions such as those seen in spastic achalasia and perhaps abnormal peristaltic patterns that may be seen in other spastic achalasia variants. Furthermore, there may be some spastic variants that may morph into other types of achalasia. Thus, we can overlay the different types of achalasia on this progression of disease with EGJ outflow obstruction demonstrating an evolving or incomplete form of achalasia, type 3 or spastic achalasia characterized by more inhibitory loss, and then type 2 with the loss of peristalsis, but prior to that end organ damage that is seen in the dilated forms of type 1. EGJ outflow obstruction or incomplete presentations of achalasia may require additional testing or monitoring or a stepwise approach to treatments. And that is because it is important to recognize that not all EGJ outflow obstructions are achalasia variants. We are familiar with other types of conditions that may cause elevated pressure at the LES and gastroesophageal junction complex, as listed here. It is this last point on which I want to further elaborate given the entity of opioid-induced esophageal dysfunction. Opioids appear to dampen the inhibitory signal of esophageal motility. EGJ outflow obstruction and spastic peristalsis is more commonly seen with this active opioid use. Clinically, findings associated with opioid-induced esophageal dysfunction are more suggestive of chest pain and less associated with dilation of the esophagus. Ideally, we should perform high-resolution studies off of narcotic medications. One of the newer technologies to enter the field of esophageal motility disorders is the endoluminal functional lumen imaging probe, or Endoflip. There are pressure sensors housed in a balloon catheter, which can be inserted transorally during a sedated endoscopic procedure. Impedance planometry allows for assessment of the esophagus in a state of distension, simulating a solid food bolus. Objective metrics include the diameter at the EGJ junction, which is 11 millimeters or higher in patients with normally relaxing LES, and distensibility, which is based on cross-sectional area and pressure within the balloon, which is determined to be around 2.8 or higher in controlled patients. The second generation of Endoflip allows for a pressure topography assessment to characterize secondary peristalsis, which normally appears as repetitive antegrade contractions as shown here. This tool may potentially be used as a screening tool. In a study by the Northwestern Group, they found that among 111 patients with abnormal HRMs, 95% of those also had an abnormal endoflip. Recently, they also published the ability for a supervised machine learning model to differentiate between non-spastic and spastic types of achalasia. Further validation is still needed of these approaches. What is perhaps equally, if not more interesting, is what Endoflip can provide beyond HRM. We are sometimes confronted with cases when the IRP is low, but clinical and radiographic concern for achalasia. In these cases, Endoflip may be able to confirm LES impairment with a low DI and predict response to treatment. An additional opportunity that we find useful in our practice is the ability to phenotype HRM diagnosed EGJ outflow obstruction and differentiate between appropriate relaxation as denoted by a normal DI and those cases with impaired LES relaxation with a low DI. We also have the opportunity to characterize esophageal dysmotility syndromes that may not be captured by wet swallows and an HRM catheter and the current classification systems, and also may be provoked with distension of the esophagus. In conclusion, our understanding of achalasia has expanded beyond the classic presentation, which often represents late stages of the disease. High-resolution manometry and Endoflip have enabled a broader range of phenotypes of achalasia and esophageal motor disorders. Incomplete or evolving patterns of achalasia and spastic variants are less predictable than classic achalasia. Thank you very much for your attention.
Thank you, Vani. That was an excellent presentation. Can I just remind the participants that you can actually ask questions by typing in the Q&A function on the Zoom, and then we can relate your questions when appropriate. Any questions from the panelists?
Yes, Vani. I think we only have one at a time for one question. So can I just quickly ask you about the Endoflip? I think you mentioned that the Endoflip has differentiating power versus the current high-resolution manometry in terms of certain things, in terms of stressing the esophagus to produce the abnormal finding. So I think under these circumstances, can this be actually used to provoke, for instance, chest pain in a patient with spastic or the type 3 achalasia?
I think that's an excellent question. I have found that in my practice, Endoflip is much more sensitive to produce these abnormalities in these patients that are chest pain predominant. And I find that they have sustained esophageal contractions or these sustained occluding contractions on Endoflip that correlate with more of the pain predominant symptoms and seem to be stimulated by that bolus distension and often mimicking their history of symptoms with solid foods.
Is there time for one question, Simon?
Yes, there is.
Thank you. Vani, I would like to have your opinion about something that is really striking. Before POEM came, achalasia was very rare in China and Japan. Now it seems to me that everybody has achalasia. And you find that this publication with thousands and thousands and thousands of patients. Do you think we are over-diagnosing achalasia or overusing POEM?
I think that our epidemiologic evidence does suggest that there is an increase in detection of achalasia. Our understanding of this disease has expanded beyond those classic presentations, and the advent of high-resolution manometry allows us to detect a broader range of diseases. And we have several studies that show an increased incidence that exists on both sides of the world. So I think that we are able to appreciate that it's both our ability to capture and diagnose what's going on with the esophagus.
Simon, may I ask you a question?
Yes, of course.
Vani, congratulations. Very clear. Your presentation was very clear. What is, in your opinion, the role of the Barium Swallow in any technique? Is there still a role for the Barium Swallow for diagnosing achalasia and PMDs or following patients after therapy?
I still love the barium swallow, and I still I like looking at the dynamic cine images to capture some elements of dysmotility in the esophagus. I like the use of a barium tablet to see if there's impaired LES relaxation that may not be as easy to determine with endoscopy. So I think it is a useful component of the initial testing. In terms of the timed barium swallow, that only works for late stages of disease. So I think that only in those circumstances, I find it as useful for the post-intervention.
Thank you.
Thank you, everyone.
There is a question from one of the participants. It says, in one of the images that you show for type 3 achalasia, also had a high DCI. In these cases of low DL with a high DCI, what diagnosis should we keep? Achalasia type 3 or jackhammer?
So I think that's a great question. Currently, our Chicago classification type 3 achalasia is dependent on a low DL. You may have a low DL as well as some high vigor or hypercontractile elements, but if it is just purely a hypercontractile swallow with a normal DL, that would either be jackhammer or EGJ outflow obstruction with hypercontractile elements. Sometimes with jackhammer esophagus, the tail of the high vigor swallow can contribute to the high RRP. Other times we see true evidence of just a primary, of an LES dysfunction.